Well, welcome, everyone. Thank you for your time today. Thank you for joining our panel. I hope you enjoy everything that we have to offer. We're here today to talk about enhancing patient outcomes using AI. Now, AI presents immense opportunities in healthcare, right? From drug discovery to treatment identification and all the way to hospital operations, just to name a few. In fact, AI has been used to detect certain kind of cancers. During the COVID pandemic, people were using AI to predict possible treatments, and the companies are now using AI in order to determine and suggest likely outcomes for people who are admitted into a hospital with certain disorders. In other words, AI is going to revolutionize this entire industry. But AI in healthcare presents certain ethical, technological, and legal issues, some of which are slowing down adoption throughout the industry. Now, our expert panel here, we're going to talk about some of these issues, and hopefully we will discuss all of these various strategies and legal and technical and ethical implications of using AI. Now, my name is Eugene Goryunov. I'm a partner in Haynes and Boone. It's a law firm that has a home base in Texas, but we have offices throughout the world. I am the co-chair of the law firm's AI and deep learning practice page, and practice group, in fact. Look, we regularly work with clients to help them overcome legal and ethical issues in implementing AI in any industry. Now, I doubt that my introducing these gentlemen will do any honors, so I'm going to have them introduce themselves. Roger, you want to start?
Yeah, absolutely. Hello, everyone. My name is Roger Diaz. Great pleasure to be here today. I'm an assistant professor of emergency medicine at the Harvard Medical School. I work at the Brigham and Women's Hospital in a research lab called Human Factors and Cognitive Engineering. And my research involves AI and extended reality, and more importantly, the human factors and usability considerations of using AI in healthcare.
Fantastic. Hardik. I'm Hardik. I'm the co-founder and CRO for Shaip, and it's amazing to be here with such a esteemed panel. And I am a technologist at heart, and I try to focus on healthcare data and AI problems, strategizing with our customers ranging from startups to Fortune 500 companies on how we can help them with their AI problems, whether it's data related, deploying related, or technology related, and deploy technology so it helps essentially the patients at the end. We have offices all across the globe. We have a growing team, and I'm happy to discuss all about healthcare AI today.
Hi, my name is Stephen Wong. I'm a scientist, actually, and a chair professor at Houston Methodist Hospital and Weill Cornell Medicine in New York. And I have about 30 years experience in healthcare and large-scale system. So previously I was a professor at Harvard, and UCSF implemented a lot of new systems, including PACS, Picture Archive Communication System, the first one we built in the country. And also I have a leadership position in Philips and Bell Labs and also Charles Schwab for a while for building a large-scale system. So my real research actually in cancer and Alzheimer's, but I also think about this healthcare transformation for years because of previous work. And always, I'm the guy who always like to bring the basic science discovery translated to real world and back. So kind of for bench to bedside and bedside to come back to bench to leverage each other. Thank you. Glad to be here.
Well, thank you, gentlemen. I'm looking forward to working with you on this panel.
Yep.
Let's dive right into it. How do you use AI in your specific companies and in your industries?
I can go first. So think about how Apple launched the App Store about 16, 17 years ago. They provided the core technology and a framework for others to build their apps on top of it. So they said that, hey, we are going to open up and provide you the data, the user information, and how to build the technologies. And then people started building apps on top of it. Some of them worked, some of them didn't. Some of them were just feeding your cat something there on the app, and others were very productive for banking and social media and other purposes. So at Shaip, we try to do something similar. We have built a core technology at the base, a clinical NLP, to essentially help others build their applications on top of it. So we see lots of use cases on a daily basis with companies from, as I said, technology companies to hospitals trying to solve several problems. Two of the use cases which we see very, very common across the board and which are very close to my heart as well relates to the patient experiences and the patient care. So the patient experience with the whole health system has been broken over the last few years. One of the reasons has been processing of claims and insurance. All of us have faced that thing. You go into a physician's office, you go give your insurance card, and they say it's going to take weeks or months to do the pre-authorization, and then the claims processing takes a lot of time. AI can actually solve that problem. It can help the insurance companies at the back end process the claims much faster, understand all the patient history, provide codes to that, and essentially help the claims processing happen in hours, minutes, rather than days and months. So that is very powerful in terms of AI, how it can help the patient experience with the whole system. The other is patient care. All of us, again, have that experience. We go into a doctor's office, and half of the time the doctor is scribbling on the laptop, writing notes, typing something, and just glances to the patient a few times. That experience for the patient is also broken. AI can help that in a lot of ways as well. So AI can essentially populate all that information, understand the history of the patient, what kind of background they are coming from, understand the diagnosis, what kind of prognosis can be recommended for that population health, and then give the recommendations to the doctors so they can actually understand that, spend more time with the patients, and understand what the background they are coming from. So these two use cases I've seen a lot being applied as far as the patient experience and the care is concerned. You guys want to add anything on that?
Sure. Raj, you want to go next?
Yeah, I can go next. So in our institution, mainly we are working on AI on the early stage of design development and initial validation prototyping. There are two main areas we work with AI in healthcare. One is on medical education, right? I'm working at the Strategy Center for Medical Simulation, and a huge challenge we have in healthcare is how to measure competence and proficiency of a health professional, right? Whatever they are like under training, or even like after training for maintaining their certification, for example. And the current methods are all subjective, expert-based, checklists, and surveys. So a lot of things we're doing is how to use AI, computer vision, for example, using the operating room to measure surgeon psychomotor skills and how those skills measure and index by computer vision can be related to patient outcomes. We're also doing something very interesting on the team level, how also using computer vision and speech recognition and natural language processing to understand team dynamics in the operating room, right? We know that more than 50% of the preventable medical errors and adverse events in surgery are due to non-technical skills, not lack of knowledge or technical skills. So we're trying to model those team dynamics using AI as well, and build that into assessment systems for training, but also competence certification in the future. That's one area in the education part and training. So objective, AI-driven, data-driven assessment of clinicians' competence and performance. And trying to validate that, not in the research lab only, but translate that into real patient outcomes. The other part is on the clinical decision support and clinical guidance. So using AI to support clinicians during complex, high-stake decision-making in the operating room is another use case that we're using right now, work with perfusionists during cardiac surgeries. And is the fact that there is a huge variability in decision-making healthcare, right? And that variability is related to issues in patient safety and quality as well. So we're using a machine learning and systems that can understand what's going on in the operating room and can, in a systematic way, help and support clinicians in high-stake decision-making. So our approach is always a human-in-the-loop approach, that the clinician is the center, And we understand AI as in healthcare, really as a augmented intelligence capability instead of being artificial intelligence replacement one. So those are the areas. But most of the things we do, they are not adopted, right? So we're working on the initial phases, on trying to understand and bring clinicians at the design phase of these systems, right? And that's what we really do in the lab, in these human factors and usability studies. What we see a lot of issues with adoption, right, is that there's a lot of effort on the design development, and then we try to adopt that into like the frontline healthcare workers, and there are a lot of issues and barriers there, mainly because they were not involved in the design phase. So a lot of things we do at the early stage, a lot of techniques we use to bring clinicians when we are designing these AI systems and get their input very, very early to increase the success of adoption later.
Stephen.
Yes, I pretty much agree with what Roger and Hardik has said in this area. Most of the AI right now in the healthcare area, mostly in the back office, IT, scheduling, operation. In fact, you have no choice. The vendor already putting the AI into the product. Use your product, you have to use AI. And for the clinical side, I see a lot of them, I call it a piecemeal automation. You have like radiology, you have AI in reading the mammogram, AI reading the chest rate, or sometimes look at ECG. A lot of product already embedded machine learning, deep learning into their product. So when they buy the vendor product, they already have it. I think one thing that Roger alluding to is right now a lot of AI, they are standalone. In healthcare, it's just like when we take care of a patient come to the hospital, it's the whole total process. We are not looking at a single pain point. You want to optimize the whole thing. So right now the hospital is, because AI is hot, everybody jump on it. All these administrator, quite cool, business innovation, all kind of thing, when they're pushing it. Lacking a very systematic way to look at the workflow, how properly designed, as Roger say, put in the right point, to instead of, otherwise the more automation adding in, end up is, I think we're lacking the effect. So far, I have a mixed feeling of the AI in implement healthcare. Everybody jump in. It's because it's hot, it's cool, everybody like it. And, but overall, end of the day, healthcare is a business. Even hospital, most of them are non-profit, still a business. And we eventually look at a return on investment. And if you don't have any benefit, if you're hurting patient, we'll just kill it. And I think the workflow, I think we are at the second, incremental, what my feeling is, incremental improvement in AI is already here. I think we need to go a next layer up, look at the total workflow of the disease management. Because every time you incorporate a new technology into the process of clinical care, you have to redesign a little bit, optimize a little bit. Just like EMR, a lot of people still complain about EMR today, no matter what. But government force it, you have to use it. But EMR actually changed the workflow. You like it or don't like it. Well, hospital had changed it. PACS, people using radiology, look at the digital film. In the old days when I started at UCSF, people were hanging protocol. You have a stack of film, you hang it up. You optimize that part. And when you change it, all these things, and be completely digital radiology, suddenly the income of radiology increased. Notice that because the billing cycle just shortened within half a day instead of a week. Everything changed, the workflow changed. And so my point is a lot of AI coming in right now, exciting AI. It needs something like Hardik and Roger say, it needs some design in the beginning. It's just jump in, put it in. I see a lot of my colleagues in healthcare system right now, just very isolated, uncoordinated implementation of AI in healthcare, which I worried because in medicine, the first thing we do is do no harm, not just improve it. And I'm afraid it's harming patients. I'll give one example. We have a lot of AI right now in doing screening. You analyze the data, but especially in the area of cancer, but we have over-screening, over-diagnosis, over-biopsy of patients. If you look at the data itself, breast cancer is a typical case. We have 700 women unnecessary biopsy per year because over-screening. All the issue, I think AI can help, but no one systematic put it together. But anyway, my point is, I like to look at it as, maybe at this stage, we should come up at the workflow level, look at it holistically, how to optimize the whole process.
Yeah.
Well, Stephen, you and Roger both mentioned that you shouldn't just dive in when you're implementing AI. What if some company is just at the entry point? What advice would you give them about creating a strategy to effectively implement AI? Right? I mean, Roger, you were talking about get engineers or get the doctors involved in early so you can get input on how to structure everything. And Stephen, you were talking about, again, avoiding the rush, taking your time, thinking through the process. What are some other strategies you can recommend?
You're the entrepreneur. Go ahead.
Sure. Yeah.
Since you opened the door, you can go start with that one.
Absolutely. I think they're very important, right? And I mean, the industry follows very well the standards like human-centered design, right? And I think when we say like clinician-centered design, it's very, very important and it's different, right? So adopting a automation in a non-healthcare industry is very, very different than in healthcare, right? For many reasons, right? And there are many things, I think, as a strategy. One is really on the early stage, right? And it's not only involving clinicians getting their feedback. There are like specific techniques, methodologies that are very successful on getting that. So one example, we're seeing a lot of like explainability, right? Discussion about explainability, a lot of companies and products about the advances, the technical advances of explaining machine learning predictions, for example, right? One of the things we're doing right now with cardiac surgery teams, and that's a research grant funded by the NIH, is that before we collect the data and create the machine learning models and test like how accurate are those models, right? We are at the same time at the beginning now testing different techniques of explainability because there are, so for example, we are having 7 different ways we can explain to clinician why that algorithm predicted them to make that decision, right? And we are randomizing them and getting like a methodological, scientific way, what are their preference, which one they trust more. We are finding, for example, something very interesting that's called automation bias, that even when the prediction, 30% of the cases we put the wrong prediction. Mm-hmm. And a lot of times, we saw this in non-healthcare, now we're doing neurologists and doing now with perfusionists. There is also a bias that you're gonna trust that recommendation even that's wrong, right? So then we can tackle that at the beginning before we have the models and the prediction. I think a lot of the focus is really on how accurate this algorithm is, right? Or it's 99% accurate. It's like 0.3% error, right? That doesn't mean that clinicians will adopt that, right? There are many other things, integration with workflow, as was mentioned. If your new technology is very good for better decisions, but creates an additional workflow, an additional cognitive load, that could be detrimental, right? So I think that's the main part for me when I think this involvement at the beginning. And thinking another strategy, right? And I think that also goes into value, right? A lot of discussions here is about business value. And for healthcare, we know where the value in healthcare, right? So we know that's like improving patient experience, patient outcomes, patient safety, patient satisfaction, reducing costs in healthcare, improving health at the populational level. And then we have 2 more of the quintuple aim right now. One is improving clinicians' well-being and professional fulfillment, right? We have a crisis now of burnout, and it costs, only in the US, estimated $5 billion of turnover and absenteeism of clinicians' burnout. So, and the 5th one is health equity. So when you think of this optics, is this, we know what brings value to healthcare. So let's think, what is the problem we want to tackle and how AI can help solve those problems or how AI can take advantage of those opportunities. Instead of, let's develop a high accurate AI, now let's find a problem for that high accurate AI to solve, right? So I think that thing that we know in business is the same in healthcare. Let's focus on what brings value to healthcare and then find how the technology can help bring that value instead of doing the opposite. Because otherwise you'll have a lot of great technology that no one wants to use, right?
Yeah. Absolutely.
Stephen, you want to take us next?
Yeah, I agree with Roger, but slightly in the negative turn. Sometimes you're in the business store too long, cynical a little bit. I've been here for 30 years, 30 plus years in healthcare business. It reminds me as healthcare is full of mom and pop shops, and they don't last very long for 30 years. And at least in the United States, most likely, also Europe, I used to run the operation in Europe for Philips. Most of them are sold by relationship. That means that you have a good relationship with the health system. Remember, healthcare is a risk-averse business compared to other business. As I said, Pierre mentioned, first thing no lawsuit, do no harm. I mean, before you really think about innovation. You may argue that, but this is the conditions, right? The CEO worry about it. So you sell by relationship means that what? The guy who have been, the big guy who have been long time sending rep to your hospital, talking to your doctor every day, just like pharma rep, medical imaging rep, they build this relationship. And sometimes, it's sad to say, not the best technology being implemented in healthcare. That's the reality. I mean, and also, from a CFO point of view, CEO point of view, you should think about it. Even you are the best technology, okay? I implemented. Can you guarantee 2 years later you still survive? And I train my whole staff around you. Look, I put an MRI machine there. MRI is just not an MRI. I built a room, magnetic room, special room. And then I train a special team of surgeons, physicians, radiology around it. And suddenly I change a different machine, different vendor, you go bankrupt. And I need to retrain whole. That's a cost. So when you are a startup to want to approach hospital, these are the things you should know about your potential customer. That's their mindset. Doesn't mean there is no strategy. It's still a strategy. You can go in, as Roger said, work with a champion, clinical champion, have influence in the hospital system to move up a little bit. But remember what? The business size always take that consideration. The risk, will you be still around? All these type of things, and what's the relationship? It's a trust business. You build up over time. So these are the things. I mean, in a way that I'm frustrated, this is exciting time. I've never seen 30 plus years in healthcare. We have so much innovation, transformation going on. And not just technically, socially, and actually macro-wise, economically, we have a lot of changes. It's the right time to transform it. As we know, we have 20% of GDPs in healthcare. We cannot sustain forever like that. There's a lot inefficient in the process. AI definitely can help. And the question is how to go in for the small shop. The big guy has advantage. If you work on EML, tough luck. If Epic Cerner doesn't work, what will you forget it? Your system cannot be integrated into a system. That's reality. That's what we know it today, right? They're gorilla there, right there. Right? So likewise, in other areas, same thing, right? You are in robotics, Da Vinci machine is there. You have to beat Da Vinci. And these are the things you need to think about it, but I think work with the I saw systems successful, I work with the champions. And John Grant work with academic medical centers. Because academic medical center physicians like Roger, they love to, like us, love to write grants. We survive on grants, frankly. Write grants to create things and build reputation in the hospital. And that will be a very helpful strategy also. And that's what I think of, yeah.
Hardik, you're one of the implementers. Do you want to give some hands-on?
Yes, I come from a very different perspective than Roger and Steve. So when we go into a hospital, a healthcare system, I echo what Roger just said, that we start with where is the pain area? What is the problem? Is it the reimbursements, the back-end office? Is it the patient experience, the patient care, the lack in patient care gap? Where is the problem area? So we start with that part first. And we have to look at it from a holistic perspective as well, that how each of these are tying into each other, because we cannot solve individual problems. We have to look at it from a holistic perspective as well. Then there are multiple factors to it. So if we identify a problem, do we have enough data to build machine learning models to it? How clean is the data? How much annotation and other stuff we'll need to do on top of it? How long the implementation will last? Will it be accepted? Will it be deployed? Will it be used? So you'll have to look at all these multiple facets, multiple factors before narrowing down that this is the area that I can start first because it maximizes ROI or brings maximum impact on whatever matrix we are defining and working on that. And then once you start building that solution in that one area, you start tying it up and kind of putting pieces of the puzzle together that these are the other areas where we can go in and check as well. And while you are deploying, you at the back of the mind, you constantly want to check what are the metrics, what is the ROI, what is the impact I'm measuring on an ongoing basis, so that I can report back or I have the details that how this is progressing overall as well. So all these factors play into the game that how am I strategizing deploying AI into hospitals and systems.
Well, thank you, guys. I mean, it looks like value and return on investment is a very big consideration. How do you balance that with the many features that AI comes to offer? Hardik, since you were last talking about ROI, I'm going to let you start with us.
Yeah, so the ROI is, again, you start with what do you want to measure? What does ROI mean to you? Each hospital is very unique, very different. So we'll have to first start with defining what does ROI mean to a specific hospital. Is it improving patient care? Is it reducing the cost? Is it improving the top line? Where is my ROI coming from? Once we decide that ROI or this is where it is coming from, then you start working backwards that to maximize this, how do I start building systems, applications, and everything around it so that I can bring maximum value to it. And any AI that is deployed, we are not at the stage where it can be completely autonomous, So there is always human in the loop in there. So you want to check that, hey, if I'm going to deploy AI in a radiology department, my radiologist at this time is reading maybe 50 charts a day. Can I use AI so that 40 of them may not be having any kind of, let's say, lesions or anything like that? I can just remove them and then just focus on the remaining 10 so I can maximize the utility of AI with the radiology human in the loop and making sure that we are actually reading more data and helping them. So that's where the ROI comes, defining right from the beginning the impact of it.
Stephen, can you follow up? But I'm also interested, where do you charge back to the patient?
You don't charge back to the patient, you charge back to payer. Careful.
Even better.
Unless you're Saudi sharks, bring all the cash come here to do it. Anyways, I think healthcare is slightly different from other business. We are also an obligation. It's a healthcare. It's human health involved. So when we make decision, ROI is important. Don't get me wrong, it's a business. You need to breathe before you can do something else. Just oxygen, you need to breathe. Doesn't mean that I survive because I want to breathe. We're mission in life. Mission in life is really better health of the people. We'll cure diseases, right? This heal suffering. So when we look at the whole thing, not just ROI, we look at it also at the same time, what's the outcomes? What's the quality of care? These are the things we also, the non-money side, actually, believe it or not, a lot of reputable hospital system will consider that. A ethical CEO will consider that, even at the way of losing money. And this is why make healthcare so complex compared to other business. Other business, a lot of business, you can just driven bottom line, very easy, one single measure. Healthcare, we have multiple measures. We have this ROI measure to survive, to breathe. And then we also really look about our mission in life, in what's the quality for the outcome patient better. At the same time, with government breathing our breath, all kind of regulation coming down us. Make sure that the lawyer don't sue us. And all these things make it very complicated. Peter Drucker, I don't remember, one of the grandfather of the MBA, he used to say that beside US government, hospital probably the least productive organized organization. Not because it's not, because the nature of the breeze is so many factors involved compared to other business. So when we measure it, we look at both all together. So sometimes we implement a product, not because it make money. In fact, we lose money. We did. We implement a couple of systems. We actually lose money. But the result, we decided it helped patients. We decided to lose money. And also a smart way to do it, because you are sending a message to other patients that quality is important in our health system. You will attract more people to come. So long term you'll win as a reputation, but short term you definitely lose money. So my point is, it's not just ROI. It's your lawyers thing, your regulations, and your this quality of care, how come patient side, all this mixed together is a formula, make it very difficult, not clear-cut formula. It's a many-level consideration. Sometimes we are losing money, even losing money, we will do it.
Lose money to provide better care for the
Correct.
patient.
Or avoid being sued by you.
Well, not by me, it would be by the patient or somebody else.
Whatever.
Exactly.
Actually, it's not joking because government, government a lot of regulation on us right now because maybe I sidetrack a little bit. The big data and AI together, they create a lot of outcome result. Mm-hmm. And a lot of government officials, very serious, look at this report, it's a great thing, stamp it, then put it into a regulation nationwide. Yeah. And really bad, because this study are not really, it applied in East Coast doesn't mean they apply in the South in Texas. And right now we are suffering all these things. And if you look at a simple case like readmission, I think a lot of them, even busy, you know that. And everybody getting about 2/3 or 1/3 of the hospital got fined every year for that. Mm-hmm. Yeah. Right, for that reason. So my point is, be careful, believe too much on these metrics generated by AI. Be careful. They need to be implemented carefully anyway.
Do no harm.
Do no harm.
Roger, you want to take us back?
Yeah, no, I'm just reflecting here, and it's very interesting, right? I think it's important when you think about return on investment and return in value in healthcare, and that sometimes the equation doesn't have only monetary figures, right? And that's very important. We can just think about, okay, we have a new imaging modality going to cost a lot of money to the hospital. We know that we're not going to be reimbursed enough to that cost, so the return on investment, if you think about monetary, it's going to be like negative or below 1, but that's proven to improve patient outcomes, right, and patient satisfaction. So when you think about value in healthcare, that's basically have patient outcomes and safety and better patient outcomes in the numerator and cost to provide that in the denominator, right? We can improve value by reducing cost, but also by improving outcomes, even if that outcomes come with like a higher cost, right? Mm-hmm. So that's the difference. But then as a system, right, that may not be sustainable, right? And then you have to think about your business, your organization, whatever is for-profit or not-for-profit, that also you have to run that as a business to be sustainable because there is cost there. And then I think that's a good point of how the way healthcare works and how healthcare payment models work. And one example that would be compatible with that model, that let's say you don't have a direct return on investment on this new technology, but by improving patient outcomes, I'll have later, based on the model, better reimbursement, right? And that's what we call the value-based payment model, that the hospital will be paid based on the patient outcomes, right? And there are some implementations of that. So that type of model, for example, could translate better patient satisfaction, sometimes like patient-reported outcomes, into a higher reimbursement to that hospital because that model, now it's a model that comply with that understanding. But I think the message is very complex, right? And it's just not like monetary figures to see a ROI of AI in healthcare.
So I think Hardik, you originally mentioned that there's just so much that goes into implementing AI. One of those components is certainly the data, yep. Right? And data, and there's a lot of it. Yeah. So, I mean, this raises a whole host of questions. I don't think we have time to address all of that, but at a high level, who owns it and what do you do with it? How do you protect it? Especially when you're dealing with healthcare and all of the rules and regulations that are surrounding it.
Well, that's $1 billion question, right? Who owns the patient data? Literally. So for the large enterprises, they can de-identify and use the data for whatever they want to build. For patients, they own the data because it's their data. For hospitals, they own the data because they created the data. So there's always this juggle going on who owns the data, and depending on how good the lawyer is or the law firm is, eventually that ends up the answer. So there are certain studies which says patient owns the data. There are other studies says when the patient gives the consent for non-commercial purposes, the hospitals can use it in whatever way or fashion they want. So it's a $1 billion question. We haven't been able to figure out who owns the data. But what value we can bring out of that data is something we have to figure out fast. About 80% of healthcare data right now is unstructured data. Doctor's notes, prescriptions, audio notes, and everything else. And how do we extract value from that unstructured data? How do we build effective solutions around those data and try to get meaning out of that? That is the next challenge that AI is trying to solve by understanding that data. But who owns the data depending on who was the better lawyer that day?
Point is not as bad. I think if you, since I talked to a lawyer, you know better. So by copyright law, and hospital actually own your data, you believe it or not, legally. Doesn't mean that they have the right to use your data randomly. It's a different thing there. So if an MRI scanner scan your body, generate the image, it's go through the machine, generate the data. So although it's your body, but it's your image, but it go through a transformation process. Just like you interview a author, write a book about this author, this famous guy, Nobel Prize winner, and you are the author, own the IP. Same thing legally. But we're dealing with human, so doesn't mean that you can randomly use the data, because there's also moral issue, ethical issue, privacy issue. So make it very complicated issue. You probably remember a couple of years ago, Google being in big trouble by taking data from Accenture, I think one of the healthcare thing, 50 state data, try to mine the thing, and also get in, I think, University of Chicago medical school dean, get EMR and go into Congress, grill them about using data, because on that, and legally they get off fine. They already, I'm sure Google has tons of lawyers handle it. And so, but moral is very bad imaged, because we put trust on you. You misuse our data. Remember, healthcare end of the day is a trust business. If you don't trust your physician, don't go there. That's all it is. And so, because after this, we start very careful. There's no clear line, as I say. It's a multiple layer things, but basic premises. Hospital now is very smart. They will ask you to sign consent. And a lot of them are research consent. Be careful when you sign, actually, you need to look carefully. I know people just sign it, just because it's such a stack of things, you just sign it. Be careful when you sign. Well, most hospitals are very, very ethical. They won't do anything wrong. Most consent you sign is for research purpose, because we need that. We cannot ask you every day if we want to improve the process, improve the outcome within the hospital. We cannot ask the patient all the time. So we can do the process improvement with your consent. We can just keep doing it without IRB, institutional board, to approve it. We have to do it every day, otherwise we can't run. But we cannot take your data to commercialize it. This is not what you sign up for your data. So this is your patient right. Patient has a lot of right in America, frankly, if you figure out. So it's one thing. The other thing is about the data itself, structured data. I would think AI, I think this conference, a lot of them still talking about EMR data. I think it's passé. When we look at it, we already passed that era. Right now, we should look at all things digital. As Roger mentioned, your video, your voice, your motion, everything. But physician basically look at your phenotype, how you walk, how you behave, how you cough. All these part of your EMR data. But we did not capture it, but AI will capture it. And AI will extract this information out. That makes the whole thing very exciting. In fact, I venture to say, I know there's a lot of human in the loop, maybe against the trend. I think human will not be in the loop. A lot of things going forward. The reason, some of them will not be in the loop, for example, like screening. A lot of clinicians do like stroke, NIH scale stroke. They spend about half of 30 minutes an hour. Ask the patient to go through, touch your nose, read the eye movement. What the heck, you have the physician to spend half an hour every day doing these kind of things. But by law, you have to do that. You can automate that. Yeah. My point is, the AI should remove this redundant, non-productive, repetitive work, such that the caregiver can spend more time with the patient at the bedside. Empathy part, compassion part, is the part that AI so far cannot give. And this is the part the patient want the most. Right now, a lot of physicians spend a lot of time administration, going through all this scaling, all these things. I think AI should, first of all, get rid of those things, automate those, get them out of the loop, so they can spend more time with the patients.
Absolutely.
Yeah.
Roger, you want to close us out?
Yeah. No, absolutely. I completely agree with that. There are like a lot of challenges. And I also think that with AI, generative AI, I know you're working with some of this, there's also a huge opportunity on the data side of creating synthetic data, right? So learning from real data, but creating huge synthetic data sets that behaves like real patients, and then building new AI instead of that. So it's using AI to do AI, right? Yeah. And I think there is a huge potential for that with generative AI as well, how you can generate patient data that's synthetic but behaves, and you can run like simulated clinical trials, right? And simulated things. That's a very exciting area that I think next time we're here, next year, we're gonna see some applications on that, and I know you're working on that as well.
Absolutely.
I see that this discussion, unfortunately our time is out. You can tell there's so many more things we can talk about. Hopefully you find these guys in the breakout rooms and have a chat with them further. Thank you very much for all of your time and all of your insights.
Thank you.
Thank you.
Actually, I have a talk right after this, just advertisement.
There you
About the
go.
workflow. I show you some case studies. Thank you.